very good evening everyone. I know everyone is tired at this point of time having intense academic discussion all throughout the day. I thank the organizers of Bengal Diabetes Conference for giving me this opportunity to be here today. Dr. Amitabh Biswas sir in particular. Thank you so much. And the topic that I have been given to deliberate for the next few minutes is something which we all do in our clinical practice on a day-to-day basis. That is in-hospital management of hyperglycemia. I'm sure all of us would be having different experiences regarding management, different ways, techniques, innovations in managing in-hospital hyperglycemia. But let us go through a few facts in-hospital hyperglycemia management, though it is very common. Let us just recapitulate the facts once. So in the agenda today, I have diabetes and the risk it confers on hospitalization, guidelines on glycemic targets, modalities for treatment in-hospital hyperglycemia, and at last, finally, the discharge management. So we see that diabetes increases the risk of hospitalization by almost 2 to 6 times. Diabetes also increases the mean duration of the stay, the length of stay in hospital. Hospital admissions in diabetes contribute almost to 50% of the cost which is involved in diabetes management. When we go into the various do's and don'ts regarding in-hospital hyperglycemia, we see that there is no particular consensus on how to manage in-hospital hyperglycemia. There are different recommendations by different organizations, by different committees. It is because of a lack of poor quality evidence. And this difference as regards the outcome of different ways of managing in-hospital hyperglycemia is in particular related to the kind of environment which the patient is in, the diet which he is taking, the nutrition, the care, the nursing care, and hence the outcomes tend to differ in different institutions and it cannot be generalized across the globe. Guidelines mostly differ regarding the glucose targets that should be managed, that should be kept, and the use of non-insulin glucose lowering drugs. How do we diagnose in-hospital hyperglycemia? Any level of blood glucose more than 140 is diagnosed as in-hospital hyperglycemia. Coming on to the recommendations, the target that we should achieve when we are managing in-hospital hyperglycemia is for critically ill patients, a recommendation of RPS to be kept between 140 to 180. For selected patients in ICU, it is of course on an individualized, we have to individualize the target. It could be 110 to 140 also, but this is highly discouraged because it could lead to hypoglycemia, severe hypoglycemia with worse clinical outcomes. For non-critically ill patients, again the target is 140 to 180. However, for those who are terminally ill, having lot of comorbid conditions, we may even aim for a higher blood glucose, close to 200 or above 200 also, in certain situations. So that was about the targets and the diagnosis of in-hospital hyperglycemia. Now, what are the pharmacological management techniques for in-hospital hyperglycemia management? It is insulin therapy, and we should also discuss in brief if non-insulin drugs could actually be used in managing in-hospital hyperglycemia. So that is a bit exciting to know what are the non-insulin drugs which can actually be used in management of in-hospital hyperglycemia. Now, for critically ill patients who come with hyperglycemic crisis, insulin therapy in the form of continuous insulin infusion is the treatment of choice for these patients. For those who are non-critically ill and admitted to hospital, a basal bolus insulin regimen or subcutaneous insulin regimens can be tried. Now, when we are treating a patient who has severe hyperglycemia or is in hyperglycemic crisis and we are giving IV insulin infusion, one of the key factors that we need to keep in mind is the risk of hypokalemia. In fact, when IV insulin is given and if the potassium comes to below 2.5, the risk of mortality is increased by almost 50%. So careful monitoring of potassium is the key when we are managing a critically ill patient with IV insulin. Once the patient is stable, we can switch from IV insulin to subcutaneous insulin. Now, what are the clues, what are the cues by which we can know that this patient is fit to be transferred from IV insulin to subcutaneous insulin. So a proper dietary intake. So when we see that the critically ill patient is recovering, he is having a proper dietary intake, he has stable vitals like a stable blood pressure, he is not on vasopressors. When he is on a static dose or a controlled dose of IV insulin, then we can plan to shift this patient from IV insulin to a subcutaneous insulin. When we are shifting from IV insulin to subcutaneous basal bolus therapy. So my junior colleagues here would think, what was the total amount of insulin that we should administer the next day? How do we write the prescription? So we can calculate the total IV insulin requirement in the past 12 hours when he is in ICU, when he or she, suppose the patient requires 1.5 units per hour in the past 12 hours, then the total insulin requirement that we would think that the patient would need is around 36 units the next day. So half of this 36 units is to be given as basal insulin and the other half as 3 shots of rapid acting or short acting insulin. That could be regular human insulin or it could be the newer insulin analogs which are available. So 50% as basal, 50% as bolus insulin or rapid acting insulin. The non-critically ill patients can be managed on subcutaneous insulin regimen when they are admitted to hospital. And recommendations for these insulin regimens are different, and randomized controlled trials using different insulin regimens have not usually come to a conclusion to show that one particular regimen is better than the others. However, randomized controlled trials have found that basal bolus insulin regimen is one of the gold standards in management of non-critically ill patients who are admitted to hospital. We can also use a basal plus regimen where we are giving a basal insulin plus 1 shot of prandial insulin depending upon which meal the patient is consuming. So we have to remember that this is a patient who is admitted to hospital. So his food timing would be different, the ability to consume different food at different times of the day would be different, and hence depending on the individualized situation in these cases, we may give him a basal plus regimen. Again, some studies have also been done with just basal insulin and oral hypoglycemic agents, even in hospital setting. And then, of course, we have our sliding scale insulin. Now, basal bolus insulin regimens, which comprises of 3 shots of prandial and a shot of basal insulin, which could be given once or even it could be given 2 times in a day, depending on the type of basal insulin that we are using. Now, this regimen undoubtedly improves the outcome in patients who are non-critically ill and admitted in hospital. It decreases the risk of sepsis, it decreases the outcomes, it improves the wound infection healing rates, it decreases pneumonia, the chances of bacteremia, acute renal and respiratory failure. But however, there's one caveat in basal bolus insulin regimen that sometimes we can be over-enthusiastic and predispose the individual to dangerous hypoglycemia. In fact, even in control settings, even in trials which have tried basal bolus insulin regimen, the rates of hypoglycemia were as high as 30%, which means almost 1/3 of the patients who are on basal bolus insulin regimen can actually face hypoglycemia, and so that needs to be kept in mind. So in hospital, we don't want hyperglycemia, but neither do we want hypoglycemia, because that would lead to the failure in the effort which we are making in improving the outcomes of the patient. Sliding scale insulin has been found to lead to a statistically increased time in range that the patient stays in hyperglycemia, and so that is to be discouraged. But patients who are insulin naive and have just mild, say, hyperglycemia, and or diabetic individuals who are well controlled, who have a stable HbA1c and do not have very high levels of blood glucose, they can be tried on sliding scale insulin. And if we find that the RBS or the random blood glucose remains higher than 180, then we can try a shot of basal insulin along with corrective doses of short-acting insulin, depending upon the pre-meal blood glucose levels. So this is to summarize: in critically ill patients having severe DKA or mild to moderate DKA, in severe DKA or hyperglycemic hyperosmolar syndrome, we use continuous insulin infusion. For mild to moderate DKA, we may try a basal bolus insulin regimen. The non-critically ill patients who do not have hyperglycemic crisis, have mild hyperglycemia, we can consider a low-dose basal insulin or OAD. Moderate hyperglycemia, we can consider a basal plus oral basal bolus. In severe hyperglycemia, where blood glucose is more than 300, a basal bolus insulin regimen remains the treatment of choice. Now, a brief discussion on non-insulin drugs. The guidelines recommend against non-insulin medications in hospital because of safety reasons and also efficacy reasons. We know oral hypoglycemic agents take longer to begin their onset of actions, and also may have a prolonged duration of action. So it could be unsafe, lead to hypoglycemia, or at times it may not be efficacious in patients who are having severe hypoglycemia. So one of the poster boy in management of diabetes is metformin. However, metformin is not to be used in hospital setting because of the excess risk of lactic acidosis which it carries, especially in patients with acute renal failure or having a compromised renal function, hepatic failure, acute hepatic failure, acute heart failure, or those patients who are awaiting iodinated contrast imaging. In those individuals, metformin is contraindicated, and since there are also EGFR recommendations for not using metformin in patients. So, in hospital patients who are most likely to have acute kidney injury, metformin is best to be avoided and not to be used. Sulfonylureas, again, we have to exert caution in using in elderly patients and also patients who are even non-critically ill because of the risk of hypoglycemia it carries. 1 in 5 patients who were treated with sulfonylurea in the hospital faced a hypoglycemic episode. So, a word of caution with the use of sulfonylurea in the in-hospital setting. Thiazolidinedials are again a big no because of the increase in the fluid retention risk of heart failure, as well as the delayed onset of action, which would not make it a very appealing drug to be used in the in-hospital setting. SGLT2 inhibitors, though they are the agents of choice to be used in heart failure or acute or in individuals who have incipient chronic kidney disease, diabetic kidney disease, they are not to be used in in-hospital setting, considering the risk of euglycemic diabetic ketoacidosis, again the increased risk of urinary tract infection, genital tract infections, which they lead to. Studies with empagliflozin in patients who were admitted in hospital did not lead to an improved outcome or improvement in the in the symptoms of dyspnea. It also did not lead to decrease in the NT-proBNP levels in the patients who were admitted and on empagliflozin. It did not lead to an improved response to diuretics or did not influence or improve the length of stay compared to placebo, even in individuals who were admitted with heart failure. DPP-4 inhibitor, they are again well tolerated and effective for mild hyperglycemia control in hospital setting. DPP-4 inhibitors like sitagliptin, linagliptin, and sexagliptin were tried in clinical trials in hospital hyperglycemia management, and they were found to be effective in hyperglycemia control. They also reduced the total dose of insulin required during the hospital stay, and also reduced the number of pricks that the individual required and improved the outcomes. So the outcomes were similar when a DPP-4 inhibitor like sita, sexa, or linagliptin was tried with basal insulin compared to a basal bolus insulin regimen in the trials in which they were individually tried. Again, GLP-1 receptor agonists are the agents of choice in individuals with type 2 diabetes who have atherosclerotic cardiovascular disease. So what about its use in in-hospital patients who get admitted for these reasons related to atherosclerotic cardiovascular disease? Again, we might use these agents for in-hospital hyperglycemia management because they have a very low risk of hypoglycemia. But again, in a patient who is critically ill, who already has a compromised oral intake, who is likely to have GI symptoms, we would not recommend the use of a GLP-1 receptor agonist in these settings. However, in those individuals in whom it has been tried, especially in the patients who are surgical candidates, it has been found that GLP-1 receptor agonist use in the pre-operative period led to better glycemic control in the peri-operative period. So, GLP-1 receptor agonist can be tried for in-hospital hyperglycemia, but there are no studies to promote its use, considering its GI tolerance. So we may weigh the risk and the benefit ratio in such patients. Again, when an individual is admitted in hospital, there are special situations like medical nutrition therapy, glucocorticoid use, or perioperative management. When it comes to medical nutrition therapy and when it comes to enteral feeding, the use of low glycemic intakes, formula feeds should be encouraged. When we are using a total parenteral nutrition, addition of a short-acting insulin even in the bag of TPN can be tried. That has led to improved outcomes compared to subcutaneous insulin regimen when tried in critical care settings. When it comes to glucocorticoid use, we know it is an important or common cause of hyperglycemia, especially when hyperglycemia and glucocorticoid use is connected. We should remember that glucocorticoid use, especially dexamethasone, would lead to a late afternoon or evening kind of a rise in the blood glucose level and would not have, these patients would not have very high fasting hyperglycemia. So what do we need to keep in mind? That in these individuals who are having glucocorticoid induced hyperglycemia, say getting admitted for chemotherapy, in these individuals 70% of the insulin dose should be in the prandial form or bolus insulin, and 30% of the insulin has to be in the basal form, unlike the previous recommendations where we use 50% basal and 50% prandial. In those individuals who are having glucocorticoid induced hyperglycemia, depending upon the individual case, we might use 70% prandial divided in 3 daily doses and 30% as basal insulin. With technology being paving our ways into our lives, so it does not spare in-hospital hyperglycemia management also. So it is a useful companion. Diabetes technology has made inroads even in in-hospital hyperglycemia management, and continuous glucose monitoring, continuous subcutaneous infusion pumps or delivery systems are important tools which can help us in achieving good glycemic control or better outcomes in in-hospital hyperglycemia management. At hospital discharge, when a patient is getting discharged from our hospital, so that is a very important time when we need to spend time with the patient, discuss the risk of hyperglycemia, how to manage them. The sick day rules need to be educated to the patient. So that is a good opportunity, a good window of opportunity for us to educate the patients regarding diabetes management. Finally, I will end with some common mistakes which we make when we are treating patients with in-hospital hypoglycemia. So one of them is using short-acting insulin only and not using basal insulin in treating in-hospital hypoglycemia. A frequent mistake that we do is missing the pre-meal insulin. If the pre-meal blood glucose is say less, so you will get a call that the pre-meal sugar was 110, say, and the sister did not inject the insulin, and hence there was a postprandial glycemic peak or excursion which led to a glucose level of 330. So that is going to give a roller coaster ride to the patient's glycemic levels, which is going to lead to bad outcomes. Again, sliding scale insulin, which is more conveniently prescribed in certain situations, that has to be discouraged. Using 40 IU syringe for 100 IU insulin syringe in patients, in hospital patients, and not respecting the electrolyte imbalance in diabetes treatment are some of the common mistakes which we make. So to summarize, insulin therapy is no doubt the cornerstone in inpatient hyperglycemia management. IV insulin remains the treatment of choice in critical care setting. In non-critical care settings, subcutaneous insulin regimens are recommended. A meta-analysis which compared different insulin regimens have not clearly showed the benefits of one regimen over the other. As with hyperglycemia, it is of equal importance to avoid in-hospital hypoglycemia also, because it is associated with poor inpatient outcomes. It leads to acquired prolonged QT syndrome, which could precipitate fatal cardiac arrhythmias. Thus, both hyperglycemia as well as hypoglycemia should be avoided in hospitalized patients. Clinical guidelines, in most scenarios, they recommend stopping oral antidiabetic agents when a patient gets admitted. However, the guidelines differ, and and the recommendations differ in different countries or in different circumstances, where in certain situations where an individual is admitted but has mild hyperglycemia, in those situations we may choose to continue with certain oral hypoglycemic agents like a DPP-4 inhibitor along with insulin regimen, be it basal insulin, be it basal bolus insulin regimen, or be it a basal plus insulin regimen. So, oral antidiabetic agents also have a place in hospital hyperglycemia management. Advances in diabetes technology are revolutionizing our lives, and so also revolutionizing the way in hospital hyperglycemia is being managed. With that note, I thank you for the patience today.